to me, it's a win-win to invest in science, because you probably will get some sort of monetary benefit. We hire people, we get jobs in the society, but we also give better health to our citizens.
This is The Rounds Table. All right, welcome back, listeners. A brand new episode in store for you today. I am joined by Dr. Mina Tadrous. Mina is a pharmacist at the Leslie Dan School of Pharmacy here in Toronto, and he hosts the I'm Pharmacy podcast. Mina, I'm so happy we had the chance to have this conversation.
Yeah, awesome. Thank you for having me, and we're excited to be here and talking about this.
Yeah, Medicine Pods is just over a year old, a year young, and as we look towards adding new podcasts and new content, I've been a big fan of your show. It feels like it delivers content related to pharmacy, related to tangential concepts, but really new content. So maybe we start, what was the origin story for your podcast?
Yeah, so I think it was really interesting. I think at one point I never even thought that I would be hosting a podcast. I don't know about you, if you ever, as a young child dreamed about it, but you know what I mean, in the sense, it wasn't part of the plan. And then we have a really great communications team at the Faculty of Pharmacy. And there was, funny enough, a group of students had tried to start a podcast. And that was actually the first season of the I'm Pharmacy podcast. They'd done a great job of selecting some really interesting topics, but it kind of lost a little steam after that first season. And the communications team, who I'd been working with because we'd been doing a whole bunch of media, met and kind of talked about the challenge in our faculty. One of the biggest challenges in the Faculty of Pharmacy is that there's a lot of people doing really cool stuff, but it feels all over the place. We have people who are designing drugs and doing very basic science. We have people who are clinical pharmacists that are in the hospitals across the street. There are people who are doing work on ethics and poli-science and people doing data stuff like I do. And so from the outside, it looks like there's no cohesive imaging. And so when the communications team was trying to come up with something, they said, well, we want to build something that's going to communicate the faculty and try to hit on the pharmacy side, the pharmaceutical science side. How do we bring that all together? And so that first season I pitched them, there's one unifying thing, and that's drugs. And we pitched that first season around what is the life of a drug, because in this building we cover all of it. Right. We cover everything from discovering that target and that molecule all the way to making sure that drug gets paid for and is stocked in the pharmacy. And so that became the first season, and that was the image. How do we bring researchers and communicate out what's happening inside this building? That was the first season that we did together. Very quickly after that, we realized that there was a lot of interest from outside the building, and how does this building fit into the broader community right here on university and college, working with the hospitals, policymakers around the corner, and what does it mean to be at U of T? And so from then, we've actually done 3 other seasons where we've built on top of that momentum, but reached outside of the building and tried to pull it in, hitting a lot of topics in healthcare and a lot of things that are grounded in the work that pharmacy does and within the healthcare system. So the idea here was, how do we better communicate what's happening in research and science out to the public? And we've learned quite a bit over the last few years.
Yeah, that makes sense. I mean, kudos to the leadership team for backing and supporting this. That feels like a tremendous amount of foresight.
Yeah, actually, to be honest with you, it was really incredible that in the very beginning, when we put the one-pager together of what this podcast would look like, the dean reviewed it. And she had a lot of really great insights on what direction, but kind of gave us the freedom to go with it. When I met with the communications team, I had 3 stipulations to me doing this. The first was, I didn't want it to just be one of those podcasts where there was just one conversation. I wanted to tell stories about science and spend time trying to communicate that. The second was that we would try to bring in lots of cool researchers and bring people in, that it wasn't about me at all. And then the third part was that every single season we had to pick a different hip hop sound to start the episodes. And so those were my 3 stipulations, and they met them, and we've been kind of, working with it since.
Nice. This really, I need to reflect on this, and I need to go to the U of T leadership for internal medicine to be like, hey, look what pharmacy has done.
Yeah.
We're trying to do the same here. Pony up some money, pony up some support. We didn't go the hip hop route. We went slightly more electronic vibes as our intro music. My brother John, I don't know if you've met him before.
No, I've never met John.
So general internist, works in Calgary. We sound the same, we look the same, but he also got the like musical gene. So like he can play the guitar, he can play the drums, he can play play the keys or something like that. So anyway, he had total control over the intro.
So did he actually make the music for your...
Yeah, it was him, and then my brother was in a band, which is, on brand with the musical gene. So I think he collaborated with one of his bandmates on the intro music.
So one thing you might not know about me, Mike, when I was in high school and college, I used to freestyle rap. And so in one of the episodes, and I won't say which one, there's an Easter egg at the end of it where I drop just a few lines to tantalize people. And that's why I was obsessed with having a hip hop, because this is the closest I'm going to get to the career. Maybe there was another life, another timeline in the Marvel universe where, Mina T is not Mina Tadrous, but, it's like a different direction.
It reminds me how when I was in high school, I could not rap. Still can't, not musically inclined, but I used to love the Friday night freestyles that was on like BET or
106
something.
in Park.
Yeah, it was so good.
It was so good, yeah.
I can remember a few of the lines, which I will not attempt to rap. So wait a sec. So this is important. So who actually picks that intro hip hop music? You pick it or somebody makes it for you?
No, so we go out there, and I work with Steve, who is the magician behind this whole podcast, and sitting in the room with us right now, and he proposes a few beats that we like, and cool. We kind of, funny enough, like it is the closest I'm gonna get to hip hop, because we try to pick sounds that are close to the cadence of how I speak, and so because that intro of how I come in over that beat is like one of the ways we do it, so it became an important part of it, and I think this is the, again, me just trying to sound as cool as I can. It's a failed mission, but we got there. Yeah.
Success. Well, it's kind of neat that you sort of refer to the work that's going on in the pharmacy school as, quote, all over the place. I'm like, that's how I would describe my research team's work. It's all over the place, but the central guiding theme is that it has to be a question that's going to potentially improve the care of a patient somewhere.
Right.
Full stop. It's got to fit under that. But it's really neat to think about like the life cycle of a medication and how do you go from molecule to then widely available medication. There must be some crazy things that you've learned over the years of this podcast for like, oh, I didn't realize that was a thing.
Yeah, that first season was really neat in the sense that, so it actually, funny enough, was starting the first season as I was beginning at the faculty, because I was a scientist across the street at Women's College Hospital, and I transitioned to a full-time tenure track role here. And so it was a really cool opportunity for me to read my colleagues' work, because to prepare for every episode, I would go read their papers to be able to ask questions, especially some of the basic sciences. So 2/3 of the graduate faculty here in and around are self-described basic scientists. Not to there's obviously a continuum in how people do their research, but I probably would have just waited for the communications to come out about some of their work. But it was a really cool chance to kind of sit down, talk to them about their work. And it was eye-opening how people do that. We had somebody in here who was developing drugs using cashew shells and thinking about, could that be helping develop a new drug that would follow the same mechanism of action as Rosie and pioglitazone.
Wow.
And then there was other people looking at previous formulations. There was one scientist in here who his drug and formulation was actually on market. And then people who talked about their commercializations, which I had no idea the number of startups that have been spinning out of this faculty, which was really neat. So I think for me, selfishly, it was such a cool opportunity to learn a lot about my colleagues, but also just to see all the interesting stories that people had to tell.
Yeah, that makes sense. And I mean, right now there's so much energy and enthusiasm going into anything related to AI, but especially like AI for drug discovery.
Yeah.
The number of pitch decks you see of, we're a company that's going to find some new target and some new molecule and cure some disease.
Yeah.
Have you had any people on the show to discuss that yet?
Well, we did have a whole episode on AI, and we had two giants. So we were lucky enough to have Christine Allen, who has a startup coming out of this faculty, but her work is not to find drug discovery, which I know is like the hot thing to find the next thing with AI, but rather how to develop the formulation. So once you found the drug, how do you build that right formulation to actually get the drug delivered? Because a lot of drugs fail because they pick the wrong formulation.
Oh, I didn't know that.
And if they pick the wrong formulation, the wrong dose, you don't deliver that drug right, it can make a massive difference. And then we had, and this is selfishly because he's one of my mentors, Mohammed Mamdani on this very episode. And you can't have an AI episode without talking to Mohammed these days.
Agreed.
And so we, I think the stats were pretty good on that one, just given how hot that topic is. But a lot of cool things happening in that space here at U of T, and obviously we had to hit on it.
Yeah.
And this upcoming season, it's going to be hard to like not. I would put money that it's going to come up in some way.
Yeah, of course. And like, I think there will be some home runs that are found along the way. I think there'll be a lot of duds and a lot of losers, but a couple home runs probably along the way. There's also been a lot of interesting work going on in the space of, existing medications now being used for some new indication. A big New York Times story on this about a research group out of University of Penn, I think. And the origin story there was that this guy was like a medical student. He developed a rare disease, I think Castleman's, and was told like, this is going to be fatal. You're not going to survive medical school and this is going to be fatal. And this motivated him to potentially find a medication that is already on the market that hasn't been tried in this. And it worked. And
really?
Yeah, and it worked. It worked for him. It's worked for other patients. And now his whole life's work is around this area, which I just find so fascinating. But whether it's that or like AI drug discovery, I feel like the rate limiting step is still just going to be a good old fashioned clinical trial.
Yeah. And I think, where my work kind of starts thinking about is like for some of these rare diseases and things like that is we find more and more targets. Because, what's happening is the low hanging fruit have slowly been picked off. Like obviously GLP-1s blew that. I never thought we'd see another blockbuster of this size, and I was obviously very wrong, and we probably will see more. But generally what we're seeing in the drug world is it's becoming more and more targeted. And so the challenge there becomes, how do we ensure that we develop clinical evidence in a proper way that's robust? But when you only have like 50 people, how do you do a clinical trial? And so we're thinking about how RWE fits into that, and there's a lot of cool things that people are doing, but also how to do it properly so that you are meeting that rigor that we're so used to with the RCT.
Yeah.
That's sort of the big challenge. But again, we had a whole episode on like the challenges of rolling out an RCT. One of the episodes we talked about was RCTs during the pandemic with the vaccines, and we actually spoke to someone who led some of those for one of the companies, and he had a really great insight on like imagine rolling out a trial, and I know you did a lot of trials during COVID, like, and every week it was changing.
Yeah.
Right? Like every week that, the patterns of disease were changing. You didn't know if all of a sudden we were going to get a new lineage of the virus and what was actually going to happen in that space. And actually that's the episode that we won an award for, looking at what the challenges are of planning trials in that space and then also in pediatrics.
Interesting. Yeah. Like I remember very early on in the pandemic, as I was caring for patients hospitalized at Mount Sinai across the street with COVID, a little bit older than me, and becoming critically ill and then going to the ICU with COVID. And it made me realize with no uncertainty that what we need right now are randomized trials.
Yeah.
That's all we need. That's all we need. And I had the good fortune of being part of a half dozen trials related to finding treatments for COVID-19. Quite the journey. And also it's like, it's pretty humbling because we were doing one clinical trial of convalescent plasma. And I remember seeing a patient and he consented. We randomized him. He did not get convalescent plasma. And then, 24 hours later, he gets worse, goes to the ICU, intubated, life support. And the whole time I'm thinking, oh man, like if only he got convalescent plasma. And you realize how powerful those cognitive biases are.
Right.
Because when we finished the trial, convalescent plasma did not work.
Right.
It probably hurt patients. So it was just like, oh man, that's the power of randomization.
But that emotion of wanting to give that patient everything you have.
Yeah. And I'm a doctor and a researcher, and still that cognitive bias is so strong. He did not get this treatment. Now he got worse. If only he got the treatment.
Yeah. Is it frustrating for you to see how fast and quickly you were able to get trials up and running during the pandemic, and then suddenly we forgot? Like, it's almost like we developed all these new solutions. Like, it was incredible how many trials you guys were able to get up and running, especially in the hospitals.
Yeah.
And then suddenly we're like back to like we have some sort of strange amnesia about what that means and how to cut the red tape about doing this work.
Yeah, it was particularly challenging because it's been the only time in my research career where things moved like so fast, right? Where we got REB review in a week, we got contracts in a week, and then boom, we're randomizing patients. Like that's incredible. It's incredible how fast you can move when you don't have a ton of hurdles in your way.
Yeah.
So yeah, and the other thing that was really interesting too was like early on in the pandemic, patients were so keen to be part of trials. So patients were like asking about, are there potential trials here? And then contrast that with like maybe the latter half, and the patient population changed, who was being hospitalized, often, not always, were people who, decided they weren't getting vaccinated, had very strong opinions about science. So towards the end of the pandemic, it was like, I don't want anything. I don't want anything. My body's going to fight this off. And it's like, what a stark contrast. That first year, patients, their family members asking us what clinical trials can they be included in.
For sure.
Yeah.
I think for us also, like, just how everyone had a crash course on how drugs were approved, right? Like suddenly people were like, when's the FDA and Health Canada approving it? Like people suddenly in the public, first of all, knew what an epidemiologist was. And then second of all, started to know what the drug approval process was like. So for me, that was kind of interesting to watch that. Yeah. But then it feels like, we've just forgotten everything.
Absolutely. And like we made a conscious effort, and it was a large team that put together the sort of inpatient trials unit mechanism. So we have kept that running, and now we've done maybe 3 or 4 or 5 non-COVID randomized trials for like bloodstream infections. And that's been exciting and pretty motivating. The
platform you built is pretty awesome.
Yeah, the platform, and there's a lot of hype around adaptive trials. Yeah. And how they're the way of the future. I find the people who say that have never actually run an adaptive trial. Because in real life, what it's meant is like every 3 months, new update, brand new, change the protocol, need a new amendment, need a new this. And you just sort of see your bank account dwindling as you're paying for your research coordinator's time for all of these updates. So I got very skeptical of adaptive trials by the end of the pandemic, but there's still a definite role for them. It's just the execution can be much more challenging.
Well, either way, I think that the trials, like the resources required for them, they take investment, right?
Yes.
But they are kind of the standard, right? Like that's what we need to sometimes make the best clinical decisions.
Yeah, and when I'm on the wards with the research trainees, like I ask them, like, why do you think if somebody comes in with a heart attack, we know exactly what drugs to give them? Whereas if a patient is hospitalized with a bloodstream infection, all of us are kind of making it up.
Yeah.
There hasn't been the same money, motivation, incentives from a pharmaceutical company for the latter. And I think a lot of the trials that we're now seeing in the inpatient space, it's because of CIHR, NIH, if that's still a thing, funded grants to actually bring them to life.
Yeah, no, it's, to that point, like I think it's scary, the cuts that are happening. The NIH has been carrying the weight. Yeah. I think, sadly, a call to our own funders here that we've been kind of benefiting from that.
Yeah.
A lot of Canadian researchers have, and globally, that we need more money in science, but also just very scary that pull away from the largest funder in the world of science to start saying like, we're not going to fund as much.
And am I right to remember that you were thinking about going to the U.S. when you were looking for a tenure track position?
Yeah.
Man, imagine.
Yeah, I think, I was just on a call right before here where I had 2 or 3 NIH grants under review that got pulled.
Oh, gosh.
We've had to like navigate what collaborations look like. My colleagues in the U.S. are unsure, like, can they even list me as a collaborator because of the current like stipulations around who can be on grants and what can happen. It was already challenging in our space to do policy work and data work that drives that and to get funded. Like, frankly, like it's been more challenging, but to suddenly be unable to kind of tap into all of that is also just frustrating. But, from our sense, at least I'm here and our roles are protected and we still have funding. Some of my colleagues in the US are letting graduate students go, shutting down labs. It's a pretty, I think a pretty dire situation for science down there, and especially for early career folks.
Yeah.
Like a lot of them don't have the capacity and the connections to get money from, in the US, like getting money from donors is like a really big thing, and that you don't get that when you're junior.
No.
And so that's where the brunt of things are happening. And I think that in the next season, I think that's going to be, just a teaser. One of the areas that we want to talk about is like, what does that mean for Canada? What is our call here to do this kind of work? Can we step up?
Is anyone listening,
Right, exactly. And I think, seeing science as an investment. Canadians value their healthcare system. They value their to me, it's a win-win to invest in science, because you probably will get some sort of monetary benefit. We hire people, we get jobs in the society, but we also give better health to our citizens.
Yeah. And I mean, we have so much room for improvement. Our healthcare system feels like it's in shambles these days. Not as bad as what's going on maybe in the US, but there's just, if there was ever a time where funding was needed to innovate and improve and try to make some real changes, now is clearly the time. So what other topics are coming up on this season of I'm Pharmacy?
So, a few things that we're thinking about is we're trying to think about the theme about this upcoming season is being a catalyst to change. And how does that change come about? Whether it's a good change, a bad change, or if it's a change that needs to happen. And I think we're going to try to hit that theme a little bit when thinking about science, thinking about how social media is affecting how science is communicated. And we want to just think more broadly about what that means to us as scientists, what that means to me as an educator, developing clinicians for the future, especially in the pharmacy world. Like, we're developing a new curriculum here at the faculty. And so thinking about how do we build out that new curriculum to meet the demands of an AI-driven society, clinicians who are going to have AI supports all around them. Like, what do all those things mean? And so that's going to be, this season is about change. And I think it's pretty obvious that 2025 has been a big year of change.
Yeah. With AI baked in so much. The other day, I overheard some medical students being like, oh yeah. And then my staff said he used Google to look something up. Can you believe that? I know. I'm like, oh, that's a gem.
That's a really good quote. That's amazing.
Yeah. Just before I was walking over here, I was talking to one of my mentees and asking her, like, what are people using on call? And, spoiler alert, they're using ChatGPT, they're using open evidence. No surprises there. And they are powerful tools. And I'm humbled how quickly they're getting better and better.
They are. Yeah. But I think at the same time, I'm also concerned about the over-reliance on them and not questioning what actually happens. So we did this interesting thing. So part of my work is we've developed these, I do a bunch of work on supply chains and drug shortages, but an important component of that was understanding which drugs are most clinically important. So to do that, what we did is we crowdsourced doctors across Canada using a validated algorithm, and we got them to score every drug available in the country on a number of components. So then I had the question of, could I get AI to score at the same, because I have this pool of all these clinician scores. Yeah. How does the AI compare to the clinicians? And, when we compared the scores, we found that the AI was way more rosy colored glasses than that, always scored the drugs much higher, and always didn't understand the nuance of a lot of the different nuances, was chasing sort of like, when you think about a single drug, the major indications, not taking into account minor indications. And so for me, it was sort of a pause to say, it was close in some places, but I think in some other areas where the nuance is really important, we're still not quite there.
100%. I have two tangential thoughts in my mind. But first, how did you get doctors to respond to a survey? Free coffee?
We paid for their time.
Okay, paid for their time. Yeah.
We
went old school.
I went old school, and we gave them, but also I think they knew that they were helping support Canada's supply chain.
Yeah.
And so the mission statement was probably the most important thing. And then we were paying for time. And as we continue to crowdsource more, pharmacists, doctors, whoever it may be that's going to help us build this, we pay for their time.
Yeah. I mean, I respect that very much so. And we did some similar work where we were trying to build out a corpus of information, and we thought, well, medications, clearly ChatGPT can just create a table for medications and, side effects, dosing, all that stuff. And we realized very quickly that the responses were all over the map.
Yeah.
And although the two trainees asked ChatGPT the exact same question, they got different answers. And that's not a bug. That's a feature, right? These AI models, they're probabilistic. They're not deterministic. So they're going to give different answers to the same question that's asked. But that's very problematic if it's in the hands of a non-expert who just assumes this is correct.
Well, what I also worry about is the bias that's in the data that comes in. Right. So, for example, we know that when there's a new drug on the market, there's a lot of literature that gets published that is funded by people who have incentives to make sure that that drug is used,
Yep.
and people who are maybe excited about new drugs. Like, it's not always like a very, evil kind of side of like making sure you use it. But, there's always more excitement of what's shiny and new. And so if the literature is leaning that way, and probabilistically it's more likely to find very positive things. And I think that's why it was scoring certain drugs way more positively than other drugs, and much higher than the clinicians, because the clinicians had a more balanced view. They were just like, they'd use the drugs, they understood where it was good and where it wasn't. But at the same time, the literature was leading it in a certain direction. And I think that's much more concerning to me, especially when you have new shiny things.
Yeah. Yeah, that definitely makes sense. And I keep going back and forth on this. I don't know if it's a fool's errand or not, but it feels like there's the opportunity for a really high quality corpus of medical information that is highly, highly curated, because all of the major large language models, they're all using the same corpus, which is like everything on the internet.
Yeah.
And advantage of that is there's so much content. But the drawback, the drawbacks are manifold. One being the biases, especially if something's brand new. So I don't know. We keep going back and forth. Should we do it? Should we not do it? But it feels like right now that is a
So we're going through
problem.
the same problem right now too. So we're trying to develop a tool that helps pharmacists and doctors respond when a shortage happens.
Okay.
Because when instantly it happens, you want to know who's going to be affected, what dosages, what indications are you worried about, who can you switch to other products, and who do you not have a choice and you want to use this? Because when a shortage happens, it's rarely zero drug. It's usually you cut your supply in half.
Yeah.
And so now you have to play scarcity, right? Like, so for some drugs, and you know this, and like some things are nice to have and some things are must have in certain populations. It could be the exact same drug for different indications. So the problem we have in that space is that if I limit it to a number of resources, so we're building this AI tool, and if I limit the resources, all I'm going to get is on-label use. And say you take a drug like norepinephrine.
Yeah.
Have you ever looked at the label and what you actually use it for?
No.
Completely different.
Really?
And so some of the older drugs and the things that we're doing, so the off-label use. And then the other problem is, as things change dramatically, are you constantly be able to bring in new information? So we have the same challenge with the balance of how do we get at off-label use and things that are actually happening in the real world, but not limiting it to just the vetted information, as long as we have the right information. And then how do we balance that with always making sure that it's constantly updated in a way? Because we know that tertiary vetted research lags. It's not fast. And so that to us is the big challenge when solving this problem here. So, I feel you on what we're trying to do. I think the idea here is to have guardrails that we can navigate with it, but also try to like maybe prioritize the information to it.
Yeah, that makes sense. And we've been thinking a lot on like how do we get the best out of AI to make life easier for physicians, for pharmacists, trainees. One tool that we created a couple of years ago now is Trial Files. And what Trial Files does is there's two pieces of kind of software under it. One is this piece of software we call Paperscrape. Paperscrape monitors Medline. It monitors Medline mainly for randomized trial from high impact journals, creates a repository of those, finds the clinicaltrials.gov identifier, scrapes more data from clinicaltrials.gov, and then synthesizes the clinical trial, like 4 sentences or less.
Yeah.
And that's been a fun initiative to work through over the past couple of years, and also to see how much better the models have gotten, but also how much the price has dropped. So every time we summarize, we are using one of the APIs through ChatGPT, and like the cost per token or like cost per word has fallen. I think it's like 500-fold compared to when we started. Yeah. So before it was like, we have these bills for $30 a month, $20 a month, whatever. Not that much, but that can, stack up. Whereas now it's like pennies.
That's awesome.
Yeah. So that's been exciting to see the price come down so much.
Have you been using that to get ideas for the podcast?
Yeah, actually, one thing we've been doing, because sometimes I will, it's my larger research lab that runs Trial Files, but sometimes I will get the email and be like, oh, I didn't know about that
cool.
trial.
Yeah.
Let's include that on the podcast.
Well, it's so hard to like stay on top of things. Like, maybe tell us, like, how do you pick topics?
For the podcast?
Yeah.
Yeah, for the podcast, how have we done it? I mean, it actually, now that I think about it, it feels haphazard, but often it's related to what Trial Files is surfacing up. Because I'm like, oh, neat, there's a trial. I didn't know about it. If I didn't know about it, there's a decent chance some listeners out there didn't hear about it either. So that's one way. And then the other way is that we like to focus just on randomized trials, and there's shortcomings with that, but we feel like randomized trials most often are going to shift the needle. So only trials, we want it to be potentially practice changing, and it's got to be related to general medicine because that's our main audience. Yeah, but it's been a lot of fun to do, and now we're sort of thinking, what do the next steps look like for the podcast? We don't have the answer, but I've written some notes from today, so maybe I'll take some inspiration from your show. The other thing we've started doing is summarizing guidelines in conversational form.
Yeah.
Guidelines are so dense. It's like 200 pages. Like no one in their right mind is going to read that whole thing.
Right.
But it has so much information that our listeners want to know about. So that's been one new episode type. Interviewing other experts has been another sort of episode type. And then we flirted with, have you used Notebook LM at all for Google? Okay, so Notebook LM, essentially you drop in a PDF and then you now have your own chatbot for that PDF. And then you also have an audio podcast of two people discussing this PDF like a conversation.
That's too cool.
Yeah. And you hear it and you're like, this sounds like two human beings talking.
Yeah.
After you listen to a couple of episodes, you'll be able to tell, oh, this is not, generated by real humans.
Yeah.
So I proposed to my brother, what if we start doing that? And he's like, no. If we're running a podcast, we have two humans talking, we're not going to farm that out. But like the NEFJC podcast, which is called Freely Filtered, now once a month, they just have Notebook LM doing the story. Yeah.
So, now we're going to get even more podcasts. Like this is going to be so anyone can make them.
Yeah. And now it's really easy with some new models. Like you could spend maybe 2 minutes just talking to this model, and then it will learn the style of your voice.
Yeah.
And then you could load in a PDF and it will review this article like it's Mina Tadrous.
Yeah.
Yeah.
And so it's so do you feel because of this that now you have to have some sort of ingenuity that's not just summarizing the article? Like, does that put pressure on you as the?
I don't think so. Like, I think people don't have a ton of time on their hands, so they are just going to use whatever channels they're already using to listen to content. I hope that. Maybe I'll be totally wrong, and maybe my brother's listening to this episode and I'll try to convince him. I actually think we should have some AI generated episodes. Makes our life easier. It can distill dense guidelines really quickly and then hear back from our users. We love it. We hate it.
What have been your big hits? Like and were you surprised by that?
Yeah, the most popular episodes without fail, we do an end of the year top 5 randomized trials from the past year. That is always the most popular episode.
That's the one I've always made sure I listen to.
Nice. There you go. I'll check my stats to confirm that. And then I would say reviewing guidelines. And then recently we've been reviewing, there's a big ADA meeting 2 weeks ago in Chicago. What were the top 5 biggest trials that came out of that? So that feels like it's drawing in listeners.
Yeah. And what do you think you're hitting there? It sounds like it's like a need to be up to date.
Yeah, that and maybe some FOMO. Like they're like, oh yeah, I vaguely saw somewhere on social media that headline, but I have no clue what was actually going on with that article. Sure. Cool. I'll spend 5 minutes to hear what John and Mike think about it.
Oh, interesting.
Yeah. That's what I think. But it'd be good to hear from the listeners. And I don't know, we don't get a ton of listener feedback on our show. Do you get many people writing in?
I get a lot of messages.
Okay.
So LinkedIn is usually the way that I get messages. I would say like 80% of it's pretty positive, and then there's the 20%. And I also appreciate it, to be honest, about feedback about things that they think we could do better, or things that they think we can be improving, or topics they think we should cover. I think because we have a wide array of topics, people feel like they can pitch us ideas, which I love. I love that because, I've always, even in my own research, I don't really come up with my own ideas most of the time. Like usually clinicians, people I talk to will say, I'm struggling with this thing or whatever, this is interesting. And then it gets my hamster going on the wheel.
Okay.
And so that's been super helpful. What we've also done is within our faculty, when we have faculty meetings, we let them know that we're working on the new season and people tell us what they think. And that's been a really great source of people pitching ideas to us as well. And so, I'm not Santa Claus. I'm not getting like piles of letters or anything like that of any sort, but we are, we do get a few messages and people reach out to us. And I think when we run into people, they'll be like, "Oh yeah, I've listened to your podcast before," and like that's always kind of exciting. I think makes you feel like a mini celeb in a way. Yeah.
Well, yeah, and you're like, oh, good, like people are listening. Like people are listening.
Yeah. It's not just my mom, because have I said this story? So one time I'm sitting in my car.
Yeah.
And my wife's like, you should do a podcast about like how drugs are approved and stuff. And I turned to her and I said, Karen, like that's literally been the first season. I'm like, you don't listen to my podcast. And she turned to me and said, well, Mina, I am not pharmacy.
Yeah. I got an even
and so,
better one.
if my wife's not listening to it, what am I going to do here, right?
I got an even better one. My brother and I, we were recording an episode. And I was saying, well, John, I mean, like, obviously, you heard my interview with Jeffrey Carson a few weeks ago. And he's like, oh, I actually
the co-host.
Yeah, I'm like, John, if you're not listening to
it,
like, what do you think
we're in trouble. Yeah,
we're in big trouble.
You got to lead by example. At least pad the stats yourself.
Yeah. I appreciate his honesty, though. That I'll give him points for.
That's awesome.
But yeah, I mean, like, we're super excited to be hosting your podcast on Medicine Pods. Our goal is that Medicine Pods will just bring together a ton of great content related to the practice of medicine. Yeah. So super excited for your podcast to be joining. And, we're happy to have you and happy to see where this kind of goes.
No, we're really excited. We're excited to be a part of that community and sharing a lot of the great things that are happening here in Toronto and around the province, around amazing things happening in both medicine and pharmacy. And hopefully, one of the reasons to do this is like cross-pollination, that some of the people that we draw in could listen and hopefully get new listeners, and do the same for some of the amazing podcasts that are going to be on Medicine Pod.
Yeah, maybe get a freestyle rap battle going on at some point.
Maybe that's what's going to come out of this.
All right, Mina. Well,
awesome.
It's a Friday afternoon, July 18th while we're recording this, so I feel like this is probably the time to wrap it up and get ready for the weekend.
Awesome. Thanks again.
Thanks, Mina. Take care.
The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.